Greetings, everyone. I hope you enjoy this presentation. It's for the development of a clinical practice guideline for patients experiencing hypertensive urgency or crisis in the outpatient setting. My name is Nadia Lopez. Committee members are Rita Wunderlich, who's the chair, and second reader is Dr. Stegman. My community member is Dr. Marina Fressman. Background or significance, basically the problem was untreated, undiagnosed, or uncontrolled hypertension. Non-adherence was a big contributing factor. It resulted in this state, and it was posing a significant challenge for the providers when these patients would present to the clinics. There are a number of 3 clinics, and I chose to use one of the clinics to start the DNP project. And the whole purpose was to address this significant challenge, and it is the focal point of the DNP project. There is compelling evidence that hypertensive urgency or crisis is the leading risk factor for cardiovascular disease and premature death, emphasizing the importance of effective treatment and adherence. Now, the location for the project was a workers' compensation clinic that treats primarily orthopedic injuries. However, this was being delayed due to the presentation of the patients and the risk it placed the providers in, as well as the patients. So the patients would present expecting to be evaluated and treated even though they had severely high readings. There's much higher risk of adverse events such as stroke, MI, renal dysfunction, or other morbidities. It's very multifactorial, and again, all of the providers were in agreement that this needed to be addressed. The review of literature found 3 common themes. There was a lack of uniform management and prevention. Many of the doctors do whatever they have experienced in the past, whatever has worked in the past. Of course, it is important that we treat the patients uniquely, right? We are all different. However, some type of uniformity is necessary. The emergency department visits and related economic burden on the healthcare system, also a significant theme because the patients will report to the ED instead of getting better managed at home. So better care and also clinical practice concerns was also a common theme. Hypertension is a prevalent condition and associated with significant morbidity and mortality. It affects approximately 32% of the population, which is pretty darn large. It ranks among the leading causes of death worldwide. Hypertensive urgency is characterized by significant elevation in the blood pressure, but without any signs or symptoms of organ damage. A hypertensive crisis or emergencies, on the other hand, these patients present with some type of symptomology. There's a lack of consensus on the optimal target for BP reduction and the time frame for achieving normal blood pressure levels. So this does create additional problems or concerns when it comes to the management. There are some safety concerns, for example, which we did find in the literature and also from my own experience. If we do lower the blood pressure too rapidly, again, this places the patient at additional risk. There were many gaps in evidence, for example, a lack of research overall in the outpatient setting in terms of the management of hypertensive urgency or crisis. The effectiveness of therapies, as well as the available standardized recommendations for the treatment. So again, a lack of research that to put all of that together. Outpatient setting in general, there's a lack of, there's a gap rather in the inequities of care, standardized care in all settings. We just don't have it. Adoption of CPGs or standardized procedures. It's very hit and miss in my experience. And then agreement on whether or not we should treat these patients is also of great discussion because many do not feel able or competent enough to be able to treat these patients on the outpatient setting. And the other issue is that there are so many different types of outpatient settings, so many different specialties, and the providers also come from various backgrounds. There's also completely different types of equipment that may or may not be available at each clinic depending on their specialty, which again poses challenges for the treatment of this condition. The theoretical framework I chose to use was a Haynes and Jones translation model. It was found to be most suitable. It does provide the structured approach to integrating research findings into healthcare practice. It addresses the gaps between evidence, research, and clinical practice, which again, it was right on target with this project. And it focuses on standardizing practice, which again was the primary goal here. Key aspects of the Haynes and Jones translation model. It uses diverse strategies to accelerate translation of research into practice. From dissemination to creation of the CPG, development and application of evidence-based guidelines to guide clinical decision-making. It has an emphasis on balancing dissemination and recognizing areas where more research is needed, which is also highly important, and addresses variability in practices and failure to uniform the practices. Methods and design. This study was quickly turned into non-interventional as there were many challenges identified very early on. The appraisal of guidelines for research and evaluation to instrument, which is in short the agreed to instrument or agreed to tool, was chosen, allows for collection of quantitative and qualitative data. There's ordinal quantitative data gathered via appraiser ratings using a 7-point Likert type scale. There's nominal quantitative data collected by asking an appraiser whether they would recommend the CPG, and there's an opportunity for the reviewers to include comments, which allows for qualitative data collection. 3 appraisers evaluated the CPG, and that is the minimum requirement. Appraisers received the tool with the frequently asked questions, a copy of the CPG at the time of evaluation, and directions were given, and all questions were answered. There was a single researcher that managed all of the data, which minimized processing errors. Data was organized, and answers were tallied. For a sample, the recruitment colleagues approached, or my colleagues rather, were approached verbally during normal working hours. All agreed that there was definitely a need for some type of guideline. They agreed with the identified issue of hypertensive urgency and or crisis. And they were very clear that there was voluntary involvement, and all fortunately were very willing to participate. Inclusion criteria, they all had to be over 18, currently working as a provider at the specified clinic and holding a current unencumbered license. The exclusion criteria was the age as well as the role that they were working in, and also the need, if they were not providing care for this particular population, they were excluded. But again, all of these providers met all of the requirements. Data analysis, again, there's a sample of 2 FNPs and 1 chiropractor. One of the FNPs had an MSN, the other one was doctorally prepared, and then we had a licensed chiropractor as well. Scoring procedures, there was domain scoring, appraiser aggregation, and overall assessment of the CPG. The quality threshold was greater than 85%, established across all of the domains. The tool utilizes, again, a 7-point Likert scale with 23 items, organized into 6 domains, and there were 2 global items that addressed the overall quality. Results. The number of items in each domain of the agreed to instrument. You can see here in domain 1, there were 3 items, 13%. Domain 2, 3 items, 13%. Domain 3, 8 items, and we had a 35%. Domain 4, 3 items with 13%, domain 5, 4 items being 17%, and domain 6 with 2 items being 9%. Comparison of minimal possible points to domain total points, you can see here. There's just a comparison by the appraisers for each domain. Again, all of the findings were very positive. There were, however, some limitations. This is a non-experimental design. No intervention was performed. So there's also a very narrow scope of the CPG, which in this case is actually necessary. And however, there was only 1 author, myself, and lack of substantive feedback. So basically all of the feedback was great, this is wonderful, yay, let's go, let's do it. Inherent limitations, causal inference, precluded assessment of causal relationships or intervention effects, outcome measurements. The scale domain scores from appraisers evaluate guideline quality but cannot predict implementation outcomes, right? They were very happy to proceed. However, who knows how well it would have been implemented or even carried out. Statistical analysis, the nature of data does not support effect size calculations or inferential data. Discussion, clinical significance, if implemented, provides needed guidance, highly needed guidance. The CPG helps to standardize care and aims to enhance outcomes, will empower the providers, it's evidence-based, and does follow current best practices. The positive impact will be on the individuals, the providers, as well as the community, being the patients. There's a potential for reducing healthcare economic burden. So we can manage these patients at the outpatient clinic. We can prevent or decrease the amount of ED visits. It provides most current recommendations, guidelines, and support for the providers. Facilitators and barriers, there was no formal quality department at this particular office or any of their offices. Lack of provider motivation, there were some concerns on their part when it came to the actual treatment. So they were very happy to have a guideline. However, they did not really want to treat the patient with the specified medication. They were concerned with performing EKGs, as some of them did not have any acute care experience. They did not know how to read EKGs, so they didn't know what to look for, which was a very valid concern. So one of the recommendations was education for these providers. They were more than willing to treat the patients once education was provided and once they felt comfortable. So that's also listed there, the need for training to promote comfort. And that, however, would pose a financial burden. Preferred provider autonomy was also a concern by the owner of the clinic. She didn't want to, quote unquote, cookie cut any of the care. So it was very clear that the CPG was a guideline, not a specific have to do. So critical thinking would absolutely be required by the providers. Owner concern of legal ramifications and cookie cutting was how she termed it. Unintended consequences, none, as the project was non-interventional. Implications to practice, recommendations for treatment of hypertensive urgency and crisis management may improve health outcomes through several evidence-based strategies. The CPG, again, will provide a standardized approach, allows for consistency in care. It is a focused assessment protocol. It's evidence-based. It offers structured education as well for the patients. So it gives the providers all of the information they need to provide education as well. Not that they have to educate on every specific topic. However, it is all available for them to pick and choose. Providers in the outpatient setting are uniquely positioned to treat these patients and, again, hopefully prevent those ED visits. Healthcare policy, the CPG developed through offers three key policy applications. Through standardization of acute hypertension protocols, it establishes competency requirements for urgent neurological assessment, offers development of quality metrics for hypertensive urgency and crisis management, and it may improve consistency, safety, and outcomes while addressing current gaps in ambulatory emergency response systems. For quality and safety, the CPG exemplifies just that. It offers specific recommendations for the management, but at the same time also allows for flexibility. In conclusion, the CPG or this project, DNP project, again, was non-interventional. The CPG was developed and consensus was achieved among the stakeholders. All of the results were positive. All domain scores exceeded the 85% quality threshold. The results confirmed the guidelines' methodological rigor and potential clinical utility. There was a unanimous appraiser endorsement and maximum ratings for overall CPG quality. Universal recommendations for implementation of the CPG was also found. Again, they just wanted to make sure that they got the needed education and support so that they could feel comfortable. Again, without a quality department, there aren't measures in place at the clinic to ensure that the implementation of the CPG would go smoothly. There's no ideas or any form of monitoring that's currently in place. So there are some issues that would definitely need to be addressed, but it appears that the company is very willing to, at some point, adopt at least some aspects of the CPG. So we do consider this a win-win. Here are the references, and again, I thank you for listening to this presentation.